Right now, at this very moment, the pill sitting in your medicine cabinet may be doing something your doctor has never told you about. Not protecting your heart, working against it. You've been taking it faithfully. Every single morning, you set your alarm, you never miss a dose. You've done everything right, and yet something still doesn't feel right. The fatigue that won't lift, the weight that keeps creeping up, the breathlessness on the stairs that wasn't there 3 years ago. Here is what nobody told you. A landmark study published in one of the most prestigious medical journals on the planet found something so alarming that an entire country rewrote its treatment guidelines. But most American seniors are still on the same pill, still trusting it, still wondering why they feel so exhausted all the time. Today, I'm going to show you exactly what that research revealed. I'm going to name the pill. I'm going to show you what it may be quietly doing inside your body right now. And I'm going to give you something very specific to bring to your next doctor's appointment. Because you deserve to make decisions based on current evidence, not guidelines written 20 years ago that nobody updated. Have you ever had a doctor sit down and actually explain this to you, the real research, not just hand you the prescription? Type yes or no in the comments right now, because your answer matters. And so does this. I'm Dr. Sarah Mitchell. I've spent over 2 decades working with patients over 60. And what I'm about to share with you, it changed how I look at blood pressure treatment entirely. Now, before I go any further, I need to be honest with you. Everything I share today is based on published research and clinical experience. Your health is unique. Always confirm with your own doctor before making any changes. And never, I want to be crystal clear about this. Never stop or reduce any prescribed medication without medical supervision. That conversation is what today's video is designed to help you have. But here's the thing. You can't have that conversation if you don't know what questions to ask. So let's fix that right now. Harold is 69 years old, retired electrician, 3 grandchildren. He described himself to me as a man who had never once been sick a day in his life, until the last 4 years. Dr. Mitchell, he said, leaning forward in my office chair, I feel like someone turned down the dimmer switch on everything. He had been on a beta blocker for blood pressure for 3 years. His numbers looked acceptable. His previous doctor had told him he was doing great. But Harold hadn't felt great in a long time. I want to come back to Harold's story in a few minutes, because what we found, it connects directly to everything I'm about to explain. First, let me ask you something. Do you know what a beta blocker actually does inside your body? Not the simplified version your doctor might have offered in a 7-minute appointment. The actual mechanism, because once you understand it, the rest of today's conversation is going to make a lot more sense. Here is what most doctors don't have time to explain. Your heart has receptors on its surface. Think of them like locks on a door. Adrenaline, the chemical your body releases in response to stress and exertion, is the key that fits those locks. When adrenaline connects, your heart beats faster. It beats harder. Blood pressure rises. A beta blocker sits inside those locks. It blocks the key from entering. Your heart rate slows. Your blood pressure comes down. For certain conditions, that mechanism is genuinely life-saving. After a heart attack, for specific dangerous heart rhythms, for diagnosed heart failure. In those situations, beta blockers have decades of strong evidence behind them. That is not what today's video is about. Today we are talking about something different. Seniors who have high blood pressure, and only high blood pressure. No diagnosed heart condition, no arrhythmia, just elevated numbers on a cuff. Because for that group, the evidence has moved dramatically. And most doctors haven't caught up. Now, I need to be crystal clear about something. This is the part that surprised even me when I first reviewed this data. In 2006, researchers published the results of the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes Trial. It followed over 19,000 patients with high blood pressure. 19,000 people. They were split into 2 groups. One group received a beta blocker combined with a diuretic. The other group received a calcium channel blocker combined with an ACE inhibitor. The researchers planned to run the trial for 5 years. They stopped it early. Let that sink in. They stopped the trial early because the results were so clear that it would have been unethical to continue. The group on beta blockers had significantly more strokes, more heart attacks, more new diagnoses of type 2 diabetes. The calcium channel blocker group had 23% fewer major cardiovascular events. 23%. Not a small number, not a statistical footnote. 23% fewer strokes and heart attacks in a group of people exactly like Harold, exactly like many of you watching right now. Following that trial and several others confirming the findings, the United Kingdom's National Institute for Health and Care Excellence formally removed beta blockers from their first-line treatment recommendations for hypertension. They are no longer the preferred choice in British medical guidelines. And yet, tens of millions of Americans remain on them as their primary blood pressure medication, often because a doctor prescribed it 5, 8, 10 years ago, and nobody has revisited that decision since. This is not your fault. The system gives your doctor 7 minutes per appointment. 7 minutes. That is not enough time to review every patient's medication history against updated research. The guidelines haven't changed for most American practitioners. And drug company incentives don't point toward reviewing older, cheap prescriptions. It's not your doctor's fault either. Not personally. This is a system problem. Outdated guidance moving through a healthcare system that doesn't reward the time it takes to revisit what's already been prescribed. But here is what that means for you. The person sitting here right now, the person who has been faithfully swallowing that pill every morning, you may be paying a price nobody warned you about, and you deserve to know what that price is. Let me walk you through the specific ways beta blockers may be working against you if high blood pressure is your only diagnosis. The first one is the one Harold described to me: fatigue and exercise intolerance. Here is what I need you to understand about this. When you block the adrenaline receptors in your heart, you limit how high your heart rate can climb. Your ceiling gets lowered. For a 35-year-old sitting at a desk all day, that ceiling may feel invisible. You never hit it. But for a 68-year-old who wants to walk to the mailbox, who wants to swim laps, who wants to keep up with a grandchild on a playground, that ceiling is right there. You hit it fast. Your legs feel heavy. Your lungs reach for air faster than they should. Exercise feels harder than it used to. And it's not because you've gotten weaker. It's the medication putting a cap on your effort. Now, here is why that matters more than almost anything else I'm going to say today. Physical activity is one of the most powerful tools we have for naturally managing blood pressure. Studies show regular moderate exercise can lower systolic pressure by 5 to 8 millimeters of mercury. In some patients, more. It strengthens the heart. It improves insulin sensitivity. It reduces inflammation in the arterial walls. But the medication is making exercise harder, which means you do less of it, which means your blood pressure needs the medication more, and the cycle continues. That's where Harold was. He had stopped his evening walks entirely. Not because he didn't want to walk, because by the time he reached the end of the block, he felt like he'd climbed a flight of stairs. He had gained 14 pounds in 3 years. His energy, he told me, felt like running on fumes by 2 in the afternoon. His previous doctor had attributed it to aging. I want to pause here for a moment, and I want you to hear this carefully. Fatigue is not inevitable. Weight gain is not inevitable. Breathlessness on a short walk is not inevitable. These may be signs that something in your treatment plan needs to be reconsidered, not accepted. Reconsidered. Let me continue with what we found in Harold's labs. The second concern I need you to understand is metabolic damage. And this one is thoroughly documented in the research. Beta blockers do something to your metabolism that your doctor may never have mentioned. They increase insulin resistance. Think of insulin like a key. Your cells have locks. Insulin is supposed to fit that lock. Open the door and let blood sugar in for fuel. When you're insulin resistant, those locks get stiff, rusty. The key doesn't turn as easily. Sugar stays in your bloodstream instead of entering your cells where it belongs. Beta blockers make those locks stiffer. A comprehensive meta-analysis published in the Journal of the American College of Cardiology found that patients on beta blockers had a 22% higher risk of developing type 2 diabetes compared to people on other blood pressure medications. And that's not the only metabolic effect. Beta blockers also raise triglycerides while lowering HDL, your good cholesterol, the cholesterol that protects your arterial walls. So while your blood pressure numbers might look better on the cuff underneath, your metabolic health may be quietly deteriorating. For someone already managing blood sugar, for someone sitting in that pre-diabetic gray zone, for someone whose doctor is watching their A1C, this is not a small concern. Harold's fasting blood sugar had drifted to 112 pre-diabetic range. His triglycerides had climbed, his HDL had dropped, and he'd had no idea that his blood pressure medication might be contributing to all three. Now, stay with me here, because this next part connects everything. There is a third consequence of beta blockers in older adults, and it is critically underappreciated in clinical practice. False. Beta blockers can cause something called orthostatic hypotension. That is the medical term for what happens when you stand up too quickly from a chair or from bed, and the blood pressure in your brain briefly drops. You know that feeling, that sudden lightheadedness, that moment where you have to grab something, where the room tilts for just a second. For a 40-year-old, mildly annoying for a 73-year-old. That moment is a fracture in waiting. Hip fractures in adults over 70 carry a 1-year mortality rate approaching 30%. 30%. That means nearly 1 in 3 seniors who fracture a hip will not be alive 12 months later. Not because of the fall itself, because of the cascade that follows. The surgery, the immobility, the pneumonia, the blood clots, the loss of independence. A medication-induced fall is not just a fall. And beta blockers, through their effect on blood pressure regulation, when you change position, increase that risk in older adults. Here is what I need you to understand. Your blood pressure reading on the cuff can look perfectly acceptable, 128/78, numbers that satisfy everyone. And underneath that reading, your metabolic health is declining, your exercise tolerance is shrinking, and your fall risk is quietly elevated. The cuff doesn't show you that. Only the full picture does. Now let me tell you what happened when Harold and I sat down to look at his full picture. He had been on Atenolol for 3 years. We reviewed the ASCOT data together. We looked at his labs, his pre-diabetic blood sugar, his elevated triglycerides, his HDL that had dropped 8 points since starting the medication. So what does this mean? He asked me. It meant his medication may have been quietly working against him in 4 different ways. And there were better options, options the research now strongly supports. Before I tell you what those options are, I need to tell you something critical, something that could protect your life if you're considering any changes. Never stop a beta blocker on your own. Not today, not this week, not because you watched this video. If you stop abruptly, your body reacts to the sudden removal of that blocked adrenaline like a rubber band snapping back. Your heart rate can spike, your blood pressure can surge, and in some cases, that rebound effect can trigger a heart attack or a dangerous arrhythmia. Any transition must be supervised by your physician, done gradually over weeks. What today is giving you is information, questions, evidence to bring to that conversation. Now, with that clearly said, let me show you what the research actually supports. There are 2 medication classes that have consistently outperformed beta blockers in seniors with uncomplicated hypertension. The first is calcium channel blockers. The most commonly prescribed is Amlodipine. You may know it by the brand name Norvas. The ASCOT trial data strongly favored this class. It does not carry the same metabolic risks as beta blockers. It does not limit your exercise capacity in the same way. And a large analysis published in the British Medical Journal confirmed that Amlodipine was associated with significantly lower stroke risk than Atenolol in elderly hypertensive patients. Now, I need to be crystal clear about Amlodipine specifically. If you have congestive heart failure, amlodipine is not always the right choice and must be discussed carefully with your cardiologist. If you experience ankle swelling within the first few weeks of starting it, that is a common side effect, and your doctor may adjust the dose or timing. Do not exceed the maximum dose of 10 milligrams daily without medical guidance. And if you experience rapid or irregular heartbeat after starting it, contact your doctor immediately. The second strong alternative is ACE inhibitors and their related family, ARBs, angiotensin receptor blockers. Medications like lisinopril, ramipril, losartan, and olmesartan. These have shown consistent benefit in older populations. They protect kidney function. They tend to show better outcomes in patients managing diabetes alongside high blood pressure. And they carry a lower fall risk profile than beta blockers. One important detail: ACE inhibitors cause a persistent dry cough in approximately 10 to 15% of patients. If you develop that cough, you're not imagining it. It's real, it's documented, and it means an ARB may be a better fit for you. They work through a very similar mechanism without triggering the cough. Now, the critical safety information for ACE inhibitors and ARBs. If you have a history of kidney disease or are in chronic kidney failure, these medications require careful monitoring of your kidney function and potassium levels. Your doctor will want to check labs within 1 to 2 weeks of starting. If you're on potassium supplements already, this is especially important to discuss because ACE inhibitors can raise potassium levels. Do not combine them with potassium-sparing diuretics without your doctor's knowledge. And if you experience sudden facial swelling or swelling of the throat after starting, stop immediately and seek emergency care. That is a rare but serious reaction called angioedema. I am giving you this level of detail for a reason. You deserve to walk into your doctor's office knowing exactly what questions to ask. Not just, can I switch? But if we consider switching, what monitoring will we need? What do we watch for? How do we do this safely? That is a very different conversation, and it is one worth having. Now, before I tell you about the alternatives, let me finish Harold's investigation, because this is the part that ties everything together. When I sat down with Harold's complete lab history, I noticed something. His triglycerides had been normal 2 years before starting Atenolol, 122. 3 years later, on the medication, they had climbed to 214. His HDL had dropped from 58 to 49. And his fasting glucose had gone from 91 to 112. Nobody had connected those dots. Each number got flagged individually. Each time he was told to watch his diet, exercise more, cut carbohydrates, but nobody looked at the full timeline. Nobody noticed that every metabolic marker had shifted in the wrong direction. At the same time, his blood pressure medication had started. Harold hadn't changed his diet significantly. He hadn't stopped exercising by choice. The medication had made exercise harder, and without the exercise, his metabolism had quietly deteriorated. So the medication that was supposed to help me, Harold said slowly, was making everything else worse. I told him it was more complicated than that. The medication may have helped his blood pressure numbers, but the full cost across his metabolic health, his energy, his exercise capacity, that full cost had never been measured. Now he knew, and now he could have a real conversation with his doctor about what to do next. Let me tell you about Dorothy, 74 years old, retired nurse. She had actually worked in cardiology for 12 of her 30-year career, which meant she had spent 12 years watching doctors prescribe exactly what she herself had been put on. I should have known better, she told me. But the thing about being a patient is that it is very different from being a practitioner. When it is your own body and your own doctor is telling you the numbers look fine, you trust. Dorothy had been on metoprolol for 4 years. Her resting heart rate was 52, low enough that she sometimes felt dizzy when she stood up. She had fallen once in her kitchen. Fortunately, no fracture, but she had started gripping the countertop every time she stood. She noticed it. It had become automatic. Her fasting blood sugar was 107, creeping toward pre-diabetic range. Her last A1C was 5.8. I referred her to her cardiologist for a full medication review. They agreed she was a strong candidate for transition. Over 8 weeks, gradually, she moved from Metoprolol to Amlodipine combined with losartan. Week 1 was uncomfortable. She felt what she described as a buzzing restlessness. Her heart rate adjusted. Her sleep was briefly disrupted. She almost called to stop. I had warned her this would happen. And because she expected it, she pushed through. Week 2, the dizziness on standing began to ease. Week 3, Dorothy called my office. I walked the entire loop around the park today, she said. I haven't done that in 2 years. By the end of 3 months, her fasting blood sugar had returned to 98. Her blood pressure readings were more consistent than they had ever been on metoprolol. She had lost 7 pounds without changing her diet, and she had not grabbed the countertop once. I feel like I got myself back, she told me. That is not a miracle. That is what can happen when a treatment plan is updated to match the current evidence. Now, here is what I want you to do with everything I have shared today. Step 1. Look at your current medication list. Specifically, identify whether you are taking a beta blocker for blood pressure and only for blood pressure, not for a diagnosed heart rhythm problem, not post-heart attack management, not for heart failure. The specific names to look for: metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. If you have one of those names on your list and your only diagnosis is hypertension, this conversation is directly relevant to you. Step 2. Before your next doctor's appointment, write down 3 specific questions. First question: was my beta blocker prescribed specifically for hypertension? And does that still reflect current evidence-based guidelines? Second question: have we evaluated my fasting, insulin, my triglycerides, and my HDL levels recently? Can we look at the full metabolic picture? Third question: based on my complete health history, would I be a candidate for a trial of a calcium channel blocker or an ARB? Those 3 questions written down brought to that appointment. Step 3. Request a formal medication review. If you have been on the same blood pressure medication for more than 2 to 3 years without a reassessment, you are entitled to ask for one. Many seniors are taking medications that were standard of care in 2005. The evidence has since moved significantly. Step 4. If any transition is recommended, confirm the tapering schedule before you leave the appointment. A responsible physician will reduce beta blockers gradually, typically over 4 to 8 weeks, with labs and check-ins throughout the process. Do not accept a plan that says just stop taking it. That is not how this is done safely. Step 5. Begin tracking your data now. Start a simple log every morning. Your blood pressure reading, your energy level on a scale of 1 to 10, your fasting, blood sugar if you monitor it, and one note about how your sleep was. 3 to 4 weeks of your own data gives your physician something concrete to work with. It changes the dynamic of the conversation. You are no longer reporting a feeling, you are presenting evidence. Now, I want to talk to you about what to expect, because this is where most people make a mistake, and I don't want you to make it. If your doctor agrees that a transition makes sense, and you begin the tapering process, here is the honest week-by-week picture. Week 1, I am not going to pretend this is comfortable. Your body has adapted to the beta blocker. When the dose begins to reduce, you may feel a mild buzzing restlessness. Your resting heart rate may increase slightly. You may notice your heart beating more noticeably. This is normal. It is adjustment, not emergency. But if your heart rate climbs above 100 beats per minute at rest, call your doctor. That is the threshold for checking in. Week 2. The adjustment symptoms typically ease. You begin to notice something you may not have felt in years. Actual energy in the late afternoon. The ability to climb stairs without that ceiling closing in on you. Week 3. This is what I call the breakthrough week. Most of my patients who have gone through this transition call or message around week 3, something has shifted. They feel it not dramatically, but clearly week 4 and beyond. The metabolic changes begin to show in your labs. Blood sugar trends down. Triglycerides begin to normalize. Your weight may begin to respond to exercise that is now easier to sustain. This is not magic. This is your body responding to a treatment plan that matches its actual needs. Now, I want to acknowledge something. Some of you watching are thinking, this sounds like too much, too many changes, too much uncertainty. I understand that feeling completely. Here is the question I would ask you to sit with. If the treatment you are on right now is leaving you exhausted, if your blood sugar is creeping up year after year, if you're holding countertops to stand safely, is that the life you want to protect? Or is that the life you want to change? You didn't come this far to simply maintain. You came this far to thrive. And one more thing I almost didn't mention, but you need to hear it. There is a subset of seniors who should absolutely remain on beta blockers, regardless of what today's research says about uncomplicated hypertension. If you have coronary artery disease, if you have had a heart attack, if you have diagnosed heart failure, if you have atrial fibrillation or another specific arrhythmia, in those cases, the evidence supporting beta blockers is strong and well established. Today's conversation does not apply to you in the same way. Your medication may genuinely be the right choice. The distinction matters. If you are uncertain which category you fall into, that is exactly what to ask your doctor. Was my beta blocker prescribed for hypertension alone or because of a specific cardiac condition? That single question changes everything. Harold's story has a final chapter. After a supervised 8-week transition from Atenolol to Amlodipine, we checked his labs at the 3-month mark. His fasting blood sugar had returned to 94 normal range. His triglycerides dropped by 31 points. His HDL rose by 6 points. He had lost 11 pounds without intentional dieting. And his evening walks were back 35 minutes, 3 times a week. I feel like myself again, he told me. For the first time in years, I want that for you. I am not promising Harold's exact results. Medicine is never one size fits all. Some of you will respond faster, some slower. What I am telling you is that if you have been faithfully taking a beta blocker for blood pressure and you have been feeling exhausted, gaining weight, and losing your capacity for the activities that matter to you, there is a conversation worth having, a conversation that current evidence strongly supports. You now have the information to have it. And I want you to know something else, something I don't say enough. The fact that you are watching this, that you pressed play, that you stayed this long, tells me something about you. You are not someone who accepts you're just getting older as a complete answer. You are someone who wants to understand what is actually happening in your body. And you are someone who is willing to advocate for yourself. That matters more than you know. Most people never ask the hard questions. They take the prescription, they accept the explanation, they come back in 6 months and do it all again. You are not that person. And that is why this conversation exists. If this video gave you something real today, if it changed how you think about your blood pressure treatment type, I finished in the comments right now. And then share this with one person, your husband, your wife, your adult child who has been worried about you. One person who has a loved one on blood pressure medication and deserves to know what this research shows. Not tomorrow. Today. I am Dr. Sarah Mitchell. Subscribe if you haven't already and turn on the bell because next week I need to tell you something I held back today. There is one thing you may be doing every single morning that makes your blood pressure medication significantly less effective. It is not what you think, and almost nobody talks about it. I will see you there. Take good care of yourselves.